Hello, today we will talk about cleaning and shaping of the root canal system. What is the purpose of doing the endo treatment? It is actually the ultimate goal is to aid in the long-term retention in patients' natural teeth in function and aesthetics. What is the purpose of doing the shaping and cleaning? 4 things: to remove the infected soft and hard tissue, to give the irrigants access to the apical canal space, and to create space for the obturation material, and to retain the integrity of the radicular structure. So, by doing the shaping, we are facilitating the reaching the irrigants to clean the tooth. Because as we know that solvents do not go further than 1 millimeter beyond the tip of the needle, so we need to enlarge the tooth as possible to that the needle can reach to the apical part and do the cleaning properly. There is a system that is called the non-instrumentation technique, which relies on the pressure that is put inside the pulp chamber, and this pressure drives in the solutions and get it inside the canals. So it is a process that disinfects the canal without the need of doing any instrumentation. They tried it in vivo, which means when the tooth is extracted, it showed good results, but when it was tried clinically, the results were not as good. Now let's talk about some considerations about the design of the files, whether they are rotary files or the manual files. We can see that there is a difference in the tip. The rotary files are rounded. The K files have sharp cutting edges, but the GT rotary file, they have rounded non-cutting tip. This space is called the flute. It is a groove between two folds, and its efficiency is relying on its depth and width. So it is considered as the working surface used to collect the soft tissue and the dentin chips. There is another concept that is discussing pitch. Pitch is the length between the tip of two folds, and this is called the helical angle. That it is the angle that is produced between the axis of the file and the inclination of each and the spiral of the file. Let's talk about the taper. What is taper? It's expressed as the amount that the file diameter increases each millimeter along its working surface, from the tip toward the file handle. So, if for example we have a file that is 25 with 0.2 taper, then we at 1 millimeter, its diameter is gonna be 0.27. In 2 millimeter, it's gonna be 0.29. So it is increasing gradually, and this is the case for the manual files. As for the rotary files, the instrument's taper varies, which means that they are not increasing in a constant manner. What we mean that there is a change, which means that there is a change in the helical angle that we discussed, and there is a change in the pitch and the taper. For example, if we are having an orifice opener, we know that it is used to to do the shaping for the coronal part, which means that the pitches are close to each other more in this area to increase the efficiency of cutting in this area more than the apical part, and so on. The famous K files and the headstone files that are used for the manual preparations under the microscope have two different shapes. We know that the K files are spiraled, and the headstone are grinding. We hear about the term austenite and the martensite when we talk about the nickel titanium rotary files. So we will discuss today what they are and how do we benefit about knowing about them. There are actually two crystal configuration of the nickel and titanium molecules, which means that the nickel titanium has two phases, its molecules can be arranged in two different shapes, the austenite and the martensite, and depending on the circumstances, it goes from this one to this one, or on the other, on the opposite, which means that usually when we do stress or pressure is applied to the nickel titanium, it is transferred from the austenite to the martensite. But when heat is applied, the austenite is capable of maintaining the heat change more than the martensite one. So the external stresses transform the austenite crystalline into a martensite crystalline structure to accommodate greater stress without increasing the strain, which means the martensite crystal configuration can handle more stress than the austenite. But when we do the sterilization cycles and we are applying heat to the files, it is there will be a change in the configuration, and it happens. This change in the crystal shape gives the nickel titanium the property that is called the elasticity, which means it has the ability to return to its original shape after being deformed. The best way to sterilize nickel titanium instruments is by heat. Do not use any disinfecting solution. It will cause corrosion and micro pitting that will decrease the efficiency of the nickel titanium in future. Now let's discuss the K-type instruments, how they are manufactured. And there are 3 or 4 equilateral flat surfaces were ground at increasing depth on the sides of a piece of wire, producing a tapered pyramidal shape. The wire then was stabilized on one end and the distal end was rotated to form the spiral instrument. A 3-sided shape is generally more flexible than a 4-sided one. The tip shows the pyramidal shape, and we can see the spirals that on the file. For the headstone files, they are produced by grinding a single continuous flute into a tapered blank. Computer-assisted machining technology has allowed the development of H-type instruments with very complex form. In the 1990s, which means after 90 years of the development of the K files, the nickel titanium was introduced to dentistry. Before that, the normal stainless steel files were tried to be engine driven and used inside the canal, but it has two problems: that the instruments were canal transport, they causes canal transportation and file fracture. So nickel titanium made a revolutionary transformation by increasing these mistakes in the preparation and the increasing the fracture because of its elasticity, and we were able to manage curved canals way better because the rotary file was taking the shape of the canal more efficient. Here are so many types and systems of the rotary files nickel titanium. The most important for us is the group 2 instruments, which has a triangle cross section and the cutting action. Here are the names of the manufacturers. The author has spoken many times about the self-adjusting file. This is it. It is an instrument made as a hollow, thin nickel titanium cylinder that is compressed when inserted into the root canal and adapts to the canal's cross section. It has continuous irrigation applied through a special hub on the side of the shank. Here, we can apply an irrigation solution that is transformed to the canal through the hollow structure, which means that whenever we are doing the cleaning and shaping at the same time. He is discussing the types in details, but here we're talking about the group 2 types. The most we know that ProTaper Universal Gold is famous. It is comprised of 6 instruments, 3 shaping files and 3 finishing files, and it has a separate kit of 3 treatment rotary files. Before inserting the ProTaper files, we must do glide path either manually or with the special rotary instruments. The glide path should be a size of 15 or 20. So we do the preparation to 15 to 20 manual, then we insert the nickel titanium instrument. The ultra stunning devices operate at 25 to 30 kHz, but the stunning devices operate at 2 to 3 kHz. When we use nickel titanium rotary instruments, the canal should be flooded with irrigants, alternating between the sodium hypochlorite and the EDTA. For the instrumentation, some manufacturers recommend a picking up and down motion. As for the Martensite alloy, we use the brushing motion, stroking against the walls upward. The incidence of instrument fracture can be reduced to an absolute minimum if clinicians use data from well-designed torque and stress studies. So, the most reason for the fracture is the clinician's handling, and also the combination of torsional load, bending, and axial fatigue, the root canal anatomy, the manufacturing process, and quality. Now let's start discussing the steps of cleaning and shaping. Let's discuss the steps. We start up by the access principles, which means that we will modify the access cavity to get a straight line access of the instruments, and this can be done with the cylindrical diamond burr, or an endodontic or a circular burr to get the straight line view or axis. Now for the coronal part modification of the root. We do the coronal, the extension of an axis cavity into the coronal most portion of the root canal is called the coronal flaring, which means we are widening the orifice of the root. And this is the sequence that is advisable. We start by irrigation of hypochlorite to control any to get a clear view of the canal opening. Then we do the glide path using a K file number 10. Then we use an orifice shaper opener that do instrumentation to the coronal part only because it is short, that it does not reach the full working length. Orifice shapers can be single rotary file, or they can be multiple ones. So if your system has sequenced orifice openers, use them gradually. After that, do a copious irrigation with the sodium hypochlorite. What is a patency file? Is a small K file, usually size 10 or 15, that is passively extended just through the apical foramen. It ensures that we maintain the working length throughout the instrumentation process. Some concern was highlighted that the patency is actually driving the contaminated debris through the foramen, and it may cause a post-treatment symptoms, but studies showed that this effect is minimal on the result, and the pain this procedure did not lead to an increase in the post-treatment symptoms. So it is advisable to do the patency to ensure that the full length of the canal is accessible. So it is advisable to explore the shape of the root canal at least to size 15 before we insert any nickel titanium instruments to the full working length. After that, we determine the working length. The best way is that we use the radiograph and the combination of the radiograph and the electronic apex locator is the best way. There was concerns about the effect of the apex locators on the pacemakers of the heart, but a study has connected directly to the cardiac pacemaker. The apex locator were directly connected to it, and electronic, they did not show any, this connection did not show any interfere with the function of the pacemaker and did not interfere with the functioning of any of the cardiac devices tested in a clinical study, which means it's safe to use the apex locator if the patient has a pacemaker. Now, after we determine the working length, we will start the instrumentation. We have several techniques. The traditional one, the step back and the crown down. The step back technique is that we start out by instrumentation the apical area, and we increase 1 millimeter as we proceed to the coronal part. This technique has some drawbacks that can cause blockage, which means if the file could not reach the apical area and the file was removed, then we did the irrigation, which means that an dentine residual has blocked the apical area, and we lose the working length. Also, if the file has passed a pre-curved negotiation file through a coronally tight canal, it will re-straighten the instrument, and we may create a ledge because we are instrumenting a curved canal with a straight file. So if we are using rotary techniques, the crown down approach is the preferable. The standardized technique is that we use the same working length throughout the whole procedure. This makes, for the curved canals shaped, this will lead to a non-unified final preparation, and when we are going to obturate the canal, we will see that there is a difference between the last file we used in comparison to the 𝐏𝐻𝐿 that we will use to operate. It will, the quota will be smaller. The step down technique. This technique is intended to minimize or eliminate the amount of necrotic debris that could be extruded through the apical foramen during instrumentation. So we start by preparing the coronal part, then we extend to the apical part. So let's read the steps from the beginning. We first insert a size 10 to 15 hand files into the coronal 2/3 of a root canal as a pathfinding files. Shaping files S1 and S2 are then inserted into the scotted canal spaces, which has been filled with irrigant. After each shaping file is used, the canal are re-irrigated, and a size 10 file is used to recapitulate, to break up debris and move it into solution. After irrigation, the apical third is fully negotiated and enlarged to at least size 15K, and the working length is confirmed. The rest of the apical preparation can be done with engine-driven pro-taper shaping and finishing hand files. So we determine the working length after we negotiate the canal to 15K file from the apex to the coronal part. The preparation is finished with one or more of the pro-taper finishing files used in a non-brushing manner. Recapitulation and irrigation conclude the procedure. Single length concept, for example, the X-shaper is a single length concept. They're saying that the X-shaper, the True Shape, and the Wave on Gold, their systems are relied on only that they all have the same length, the files, which means that they do not have an orifice opener and the finishing that have a variation in the length. And they're saying that they're getting good results. As for the hybrid technique that combines involves a coronal pre-enlargement followed by various apical preparation sequences, that we first do the coronal enlargement, then we do the apical preparation by sequence, each by each. What is the benefit on combination manual and motor driven instruments? That the hand instruments secure a patent glide path, and the taper rotary instruments efficiently enlarge coronal canal area. These tapered instruments allow additional apical enlargement. So we do the apical enlargement first with the manual instrumentation, and we do the glide path with the manual instrumentations. But to get this tapered final result, we use the rotary files. Let's discuss some irrigation. Let's discuss some irrigation solution. The most famous and the oldest of them all is the hypochlorite, which was introduced to the intracanal irrigation in 1919. It's mode of action that it breaks the peptide links of the proteins, and it combines with the amino group and releases hydrogen. So we get an NaCl chlorine, which plays a vital role in the antimicrobial effectiveness. Necrotic tissue and pus are dissolved, and the antimicrobial agent reaches and cleans the infected area. Also, the sodium hypochlorite acts as an organic and fat solvent, which means that it reduces the surface tension of the remaining solution and act as a lubricant. It is a strong base, and its pH is greater than 11. This high pH interferes in cytoplasmic membrane integrity due to irreversible enzymatic inhibition. Let's discuss the effect of increasing the temperature of the hypochlorite if it alters its efficiency in the dissolving the organic substances. When its temperature was 45, its efficiency was the same as the control group, which means that there was no change between the 45 degrees and the 20 degrees. But when it reached the 60 degrees, almost complete dissolution of tissue results. So the increase of the temperature can be done with ultrasonic tips. It must reach 60 degrees to get the efficient dissolving property. For the concentration, the hypochlorite with high concentration has a better tissue dissolving ability, but if we use lower concentration with high volumes, it acts equally in the effectiveness. So it is safer to use the low concentration with high volumes. It's important to continue with to use the hypochlorite in continuous manner throughout the instrumentation, and to leave it for 1 to 2 minutes after completing the instrumentation with activating it. Let's discuss its toxicity and the potential of getting the hypochlorite accident. It happens in the maxillary teeth more than the mandibular, and in the posterior more than the anterior, because it is a dissolver of organic matter. When it reaches the periapical area, it causes a dissolving of the blood vessels and causes hemorrhage, which results in edema and swelling. To gain rapid pain relief, anesthetic infiltration has been attempted. If the swelling is present, infiltration anesthesia is contradicted to avoid spreading of any existing infection. A nerve block should be used instead. Here we have a case where the dentist was treating the tooth number 3, and the patient reported pain. On a return visit, an abscess was diagnosed and incident. Then, after 3 weeks, we started seeing an osteonecrosis of the area. As with dealing with these situations, we must give cold compress in the first day to reduce the swelling. Then, after day 1, we use warm compresses and frequent warm mouth rinses for stimulation of local systemic circulation. For the use of antibiotic, it's not obligatory. It is only recommended if the case is in high risk. And if we want to continue the endodontic therapy, we will use the saline and chlorhexidine as a root canal irrigants. But unfortunately, usually the patient, after the trauma happens, loses his trust in the clinician and refuses to achieve the treatment and to continue the procedure. For the chlorhexidine, it was first presented as an antiseptic cream used for the skin. Its mode of action, it is capable of binding to the negatively charged bacteria to damage its cell wall. It was found that chlorhexidine was applied as a rinse in the extraction site of the 3rd molars on the day of surgery, and several days after, it was reported to reduce the incidence of alveolar osteitis. But its toxicity is more than the povidone iodine. In comparison between the chlorhexidine and the hypochlorite, hypochlorite has a dissolving tissue property that the chlorhexidine lacks of. They should not be combined together because they produce a precipitate, a colored one, and they. Now let's talk about the decalcifying agent, which is the EDTA. Here we have the EDTA applied to a tooth, and we can see, and this tooth was sectioned to 3 parts, coronally, middle, and apical, and we can see how it penetrates through the dentinal tubules in comparison to the irrigation with water by itself. And this penetration was mostly in the coronal part, and it decreased as we went apically. We can see the effect of the EDTA under the microscope, how the surface becomes clean. It is used less than a minute, and it should not by any means be increased in its temperature beyond 20, because it decreases its efficiency. Let's talk about calcium hydroxide. It is used as an intracanal medication in necrotic cases to eliminate any bacterial presence. It can be applied using a lentiole spiral or with injected through a syringe. It has some limitations, like the residual covering the canal can reach to 45%, and this shortens the setting time of zinc oxide original based sealer, and it may interfere with the seal of the root filling and compromise the quality of the treatment. Some studies has limited its effectiveness in eliminating the bacteria, and other studies supported its effectiveness. We can use the chlorhexidine as a potential replace of the calcium hydroxide as an intracanal medication. So, in summary, irrigation is an essential step in root canal treatment to ensure disinfection. Sodium hypochlorite is the irrigant of choice because of its tissue dissolving and disinfecting properties. EDTA or other shelters should be used at the end of procedure to remove the smear layer, followed by a final flush with hypochlorite for 1 minute to maximize the cleaning efficiency and to minimize dentine erosion. For the activation, we will discuss several instruments or devices that do this procedure. We have the sonic activated irrigation. We have this device. It is a manual one. We inject here the syringe with the hippo inside it. Then we push the button that go this way to cause vibration, a sonic vibrations of the irrigant, the solution inside the canal. And we can use the ultrasonic tips that are passive. What do we mean by passive irrigation? We mean that it is a non-cutting action of the activated file, which means it must be entered the file passively, not touching the canal walls. It is only transmitting acoustic energy from an oscillating file or a smooth wire to an irrigant in the root canal. That's it. This device acts as does the irrigation and the activation in the same time. Here we put in the large syringe, we put the hypochlorite and we connect this tube to it, and the other side is connected to the ultrasonic engine. Then we set the speed and the amount of suctioning of the delivering of the solution into the canal. Then we activate it, and the suctioning is the extra orally, which means it's not from this device. Another device with the same idea that has the syringe directly connected to the activation engine. The gentle wave system is made in the US. It uses multi-sonic energy to develop a broad section of waves within the irrigation solution to clean inside the root canal system. It has two main components, a handpiece and a console. The gentle wave irrigation was superior to needle irrigation, but statistically similar to continuous ultrasonically powered irrigation. For the laser-activated irrigation, it was not an alternative, but a possible supplement to existing protocols. It has the effect of disinfecting the canal system beyond 1 millimeter of dentin. We must differentiate between two causes of instrument breakage, which is the torsional and the flexural. The torsional fracture occurs when an instrument tip is locked in a canal while the shank continues to rotate. The flexural fracture occurs when the cyclic loading leads to metal fatting, which means the cyclic fatting, and in the nickel titanium alloy until it reaches the threshold of breakage. Now let's read together the overall protocol of cleaning and shaping. Using well-angulated preoperative radiograph to analyze case difficulty using well-established parameters. Place rubber dam and estimate the working length. Prepare a conservative access cavity sufficient enough to reveal all root canal orifices. Scot canals with a 10K file in the presence of a lubricant. If the selected series of rotary instruments advances easily to the estimated working length, confirm patency and determine working length using an electronic apex locator. If the instruments meet resistance and the file does not progress gently to working length, use a dictated nickel titanium instrument. It is prudent to modify the orifice to create a coronal receptacle for the subsequent rotaries, negotiate, confirm patency, and determine the working length. Create a producible glide path to working length with appropriate instruments. Irrigate with sodium hypochlorite throughout the shaping procedure. Advance the selected series of rotary instruments passively in the presence of sodium hypochlorite to shape the middle third. When shaping canals that have larger buccal dimension, cleaning the files using an alcohol moisturized gauze. If the selected rotary does not progress easily, remove irrigant, recapitulate with the 10K file and choose a different, often smaller instrument. Use copious irrigation, re-verify canal patency and working length throughout and until you complete the shaping. What about the protocol of irrigation? Irrigate using copious amount of sodium hypochlorite. Activate the irrigant. Select irrigation solution for smear layer management. Perform final irrigation. Then dry the canal to undo the three-dimensional filling that will be discussed in the next chapter. Restore endodontically treated tooth in a timely manner. See you soon. Endodontic therapy is directed toward one specific set of aims: to cure or prevent periradicular periodontitis. The ultimate goal is to aid in the long-term retention in patients' natural teeth in function and aesthetics. The primary objectives in cleaning and shaping the root canal system are to remove infected soft and hard tissue, give disinfecting irrigants access to the apical canal space, retain the integrity of radicular structures. Solutions have been shown to progress only about 1 millimeter farther than the tip of the needle, so the needle must be inserted as far as possible in the tooth, reaching the apical area. Manual instruments are now mainly used to glide path the canal and maintain patency, and to do recapitulation between the irrigation and to explore calcified canals. As for rotary files, they are used mainly to do the preparation in crown-down technique. The irrigation protocol is hypochlorite, activate, saline, EDTA, saline, and we finish the irrigation with sodium hypochlorite or with chlorhexidine. We can heat sodium hypochlorite using ultrasonic tips to reach 60 degrees to increase its efficiency in removing organic substances. As for EDTA, it should not be heated higher than 20 degrees, which means it must stay in the room temperature. Hypochlorite in low concentrations and copious amount has the same effect of using it with high concentration. So to be more preserver, we must use it in low concentration and a lot of quantity. The full procedure protocol, starting from reading the radiograph until doing the restoration, is discussed in the last 3 minutes of the video you are watching now.